This is the first ever Dissociation Q&A hub. I am Tracy Peary. I own Hope for the Journey in Texas and have decided to start trying to help clinicians feel more confident working with dissociation. And so I'm super excited to have this little bit of time to answer questions and have the ability to go deep with people's fears and confusions and questions about dissociation. So that's what we're doing today. I'll tell you a little bit about me just to kind of get started for those of you that don't know me. And then I do have some questions that are frequently asked questions that we can kind of get started with. And if you are watching this afterwards, you can always reply to the email and ask any questions that you might have for the next week if you're going to be able to miss or have to miss the live piece. But so let me tell you a little bit about me. I'm Tracy Peary. And I own Hope for the Journey. We have offices in Round Rock and Austin. And our team specializes in trauma, particularly sexual trauma. So we work a lot with complex trauma and dissociation. And, as a teaching practice, I have clinicians that are anywhere from grad school level all the way up to lots of experience. And so we are constantly talking about dissociation. And one of the things that I've noticed is that clinicians tend to be pretty confused about it. A lot of the trainings that are out there will tell you the what about dissociation, like what it is, what the research says about it, and that sort of thing. Um, but the actual like sitting down and applying that to what it feels like to be in session with your clients is sometimes missing. And so that feels really like there's a big gap there, and it creates a lot of feelings of insecurity. It creates a lot of scare, like feelings of being scared. You know, most of the clinicians that I talk with and work with are wonderful clinicians and super grounded in wanting to make sure that their clients, that they're working with them in a way that is safe and effective. And so it's really important to be able to take that knowledge that you have about dissociation and apply it in a way that's meaningful with your clients. And so that's what I hope to do with these Q&As, is to help clinicians to feel more confident, to start trying some of these things, to take on some of these clients that have complex trauma that maybe you've steered away or referred out in the past, and to know how to get your questions answered so that you can be safe with them and help these clients, because there's so many people out there that need good help, and there's so many people that unfortunately get wounded in therapy just because the clinicians don't know what they don't know. And so that's the purpose of today. So maybe we'll do a poll. Let's start with a poll with who's here and make it a little bit easier. So on a scale of 1 to 10, how confident do you feel working with dissociation? For those that are here. So 1 is scared and try to avoid it at all costs. And then 10 is expert level, love it. And so you can do anything between 1 and 10. Okay, since we don't have any questions quite yet, let me go ahead and talk about a question that I get a lot. one of the first things that a lot of people will ask is, what is dissociation? Like, how is it different from normal daydreaming or spacing out? And how do you know, like, what it looks like in therapy? And the answer to that question is that, um, you know, dissociation at its core is a coping skill. It's just like, um, eating some chocolate. It's just like, um, I don't know, yelling at somebody and releasing some frustration for you. It's just like, wrapping up in a warm blanket and, snuggling on the couch to help yourself kind of chill out, or a warm cup of tea. It's something that we learn to do that helps us to deal with the emotions of what is going on in our life. And so the difference between daydreaming and spacing out, really, the answer to that is that daydreaming and spacing out is dissociation. It's just at the normative levels. So, really, what you need to think about is dissociation is not just one thing, it's more like a scale. So, dissociation happens from that normative side, it's spacing out. So, the typical example that people think about is like, I'm driving in the car on my way to and from someplace I go all the time, like to the office. And I'm on my way home and I drive into my driveway and I realize I don't really remember the trip. I was zoned out the whole time. I was still driving and driving safely. So if somebody had pulled in front of me, I would have responded, and I probably would remember that at that point. But I'm just at the place where, I was just spaced out the whole time. Maybe I was thinking about the day, or maybe I was, for me, I might be likely kind of going over and over and over something that maybe felt a little off, or, um, like a conversation that didn't go well, or something like that. And but I was not really paying attention to the, to what was going on. So then, that's on the one end, and at the very end of the spectrum is what we look to for like a dissociative disorder. So we might think of DDNOS or DID, dissociative identity disorder. And when we have dissociation at that level, we have big gaps in memory. We have big gaps in awareness. So there, imagine that your brain is like a hallway, and, if you are in normal times, all the doors to all of the closets and doors are open, but you may not be paying attention to all of those closets. And so there may be times when you get really focused on one area of the hallway and you're not paying attention to another. And that's kind of, like a normative dissociation. But if you're in the place of a dissociative disorder, we've got closed doors, and even some of them are hidden. So you might have like a hidden doorway behind a bookshelf, and you're not even aware that there's a whole room behind there. And that room has its own personality, and it's got its own thoughts, and it's got its own books and its own little way of looking at the world, or trying to help you stay safe, and you're not aware of it. And so that piece of it being, like, surprising when you find that new room, if someone were to open it up or something jars it and all of a sudden that door is open to you, you would be like, what in the world? And you would have to resort how you think about your entire place now, because you've got this whole extra room that you didn't know about. So that's kind of the spectrum. In the middle is where we get with PTSD, or PTSD with dissociative subtype. And that's where maybe we've got gaps in our memory. Maybe there's pieces of our memory that we don't have. So, for instance, a good example of that might be, I can remember what happened, but I'm disconnected from the emotions or from the body sensations. And so There's more awareness. I'm aware that there's a room, a closet that's in there, but maybe the door is shut, or maybe I only want to peek in, or maybe all the lights are out. And so I can't really see everything as clearly as I would be if I had full access to that room. So that's how I like to think about kind of the range of dissociation. And so, as a therapist, it's really important to be able to know what level of dissociation our client comes in with, right? There's, you know, you can't look at someone and tell always. People always think that they look at the movies and they think about Sybil and they're like, there's no way that somebody with dissociative identity disorder could trick me, right? Because they're thinking that somebody's going to come in one day wearing a cowboy hat and wearing glasses, and then the next day they're going to come in and they're like this little child sucking their thumb and in the fetal position. And while there are some aspects like that, there's most people with DID don't present that way. And really, the whole idea about dissociation is lack of awareness, right? Well, if it's a coping skill, the goal of that coping skill is, yes, to help you feel better, but also to help you survive an unsurvivable experience. So when you have something like dissociative identity disorder, and there's a lot of things about your experience that have been broken, that have been so overwhelmingly painful that you can't see it, or at least were that way for you when it happened, because it may have happened for you when you were really, 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 really little, and at that time your resources were overwhelmed. And so now maybe you're an adult and you've developed DID as a coping strategy. And the appearance, in order for you to function, you've got to have the appearance of looking quote unquote normal, right? And so that's what DID does. It's kind of like a mask that people put on in order to not only keep yourself from knowing that those bad things were there, but also from keeping everyone else from knowing that. Because it's dangerous. If other people know that you've had these horrible things happen to you, you're more likely to be targeted. You're more likely to be abused again. And so oftentimes that's what DID is about. It's about a mask that goes on. So if you go in to session thinking that you're just going to be able to see it, the likelihood is that you're going to have client after client after client that are going to surprise you, that are going to trick you. And they may or may not be tricking you on purpose. They may be tricking you on purpose, or a part of them might be, but also there could be a complete lack of awareness of that. And it can be that they've got opposite parts, right? Or opposite sides of themselves, a part that really wants to get healed and a part that desperately wants everything to stay the same because the idea of change is so overwhelming and we don't know what's on the other side of that change, right? We know what this is. So even though this might be terrible, at least we know what to expect. And so that's oftentimes what will happen. And so then how do you assess for this? Well, there are some good assessment tools out there. The DES is probably the most commonly used one. The Dissociative Experiences Scale is a scale that people get. It's 10 questions, easy to answer, easy to score. The problem with the DES is that it doesn't give accurate results most of the time. There's a high likelihood that the way that someone responds, if they respond and they get a low score, there's still a high likelihood that they could have severe trauma, severe dissociative disorder going on, and they're just not aware of it, and so they scored low on it. Or there's a part of them that is, keeping those scores low so that you don't know. And so I'm actually a much bigger fan of the mid assessment. And I should have looked this up before. I can't remember what MID stands for. It's like Minnesota Inventory of Dissociation or something like that, but don't quote me on that. But the MID assessment is a much longer tool, and it definitely takes some training and some practicing to be able to really get the most out of it. It's certainly just like the DES, it takes a follow up interview, but it's a much better tool at being able to really have a good understanding of what's going on with your clients. And so that you are able from the start to create a treatment plan for your clients that is safe, that's comprehensive, and that is attuned to what where they need to start. And that can make your success so much better. The average person with a dissociative disorder stays in treatment for 3 to 5 years before the dissociative disorder is even known, even diagnosed. And so think about that as a clinician. You're working with your client for 3 to 5 years, building good rapport, trying all kinds of things, but you don't know that there's this significant piece. You don't know that all these rooms are hidden that could have bombs in them, right? Could have big, explosive things, or they could have pieces of the puzzle that completely change how you view what the right treatment is for your client. And so I'm a big proponent for getting that information up front. And I'm a big proponent, even if you don't want to specialize in complex trauma, don't want to specialize in dissociative disorders, don't want to maybe advertise it because it's not where you want to live with all of it. It's not your ideal client or what have you. It's super important for you to know because it may save you a lot of time, and certainly it'll make things safer. So, one of the questions that I get all the time is, how does dissociation fit into the broader category of trauma responses? Right? So, like, where does it lie? And we've already kind of talked about how there's a scale that you think about um, with dissociative disorders or with dissociation just in general. Everything from normative all the way to very severe complex trauma. And and so it's really it's helpful to understand that when someone is dissociating, they are disconnecting from their immediate reality, right? So they're just separating themselves from the experience that they're going through, whether it's in the moment or it's in reliving it. So when you're thinking back, when there's a flashback, that sort of thing. When we're dissociating, we're just separating a little bit from it, which, as you can imagine, would be really helpful to do. And so some people do that on purpose, right? Some people make an active choice. Like I've heard clients when they're telling their story saying, it was so overwhelming for me that I just in my head started singing this song. And I started imagining myself in this faraway place where none of this stuff was going on. And they open up this imaginative, safe place for themselves to go to. And they just are able to take their attention there and in that way disconnect from what's going on. And so they can choose to do it at that point. Sometimes they choose to and learn how to do it after the fact when there's maybe intrusive memories coming in or flashbacks, or they just don't want to think about it and they're actively avoiding the memory. And so um, that coping skill can be something that can be consciously chosen and developed, and it also can be something that is it also can be something that is, oh, I have several questions on the right side panel under live chats, is what I'm getting from my wonderful client care coordinator who's helping me out. Thank you, Nia. Okay. Hi, everybody. Now I can see. Thank you, Nia, for letting me know that there's a chat. Hi, Jay. I'm so glad you were able to make it. And hi, Haruna. Jay has a question. Let me see if I can get to it. Jay, you can ask your question. Nia says, are there different, how can a therapist tell if a client is dissociating during session? In what ways can dissociative patterns interfere with the therapeutic process? And how can we work together to address these disruptions effectively? And are there different types or levels of dissociation? Okay, so I already answered that one. How can a therapist tell if a client is dissociating during session? The common answer to that is that people will kind of phase out their gaze, or there'll be some sort of a shift. And if you're really paying attention and you know your client pretty well, you can start to learn about those slight things. You also might feel it in your body. I will oftentimes start to feel really sleepy and tired when a client is dissociating in session. Some therapists say that they can feel this, some therapists don't. To me, it's like a super litmus test. I love it because as soon as I start feeling sleepy, I know to just check in on my client and see what their experience is like and bring them back, try and engage them in a coping skill. But there's also times when I don't know that my client is dissociating. So I build in regular times of checking in. And we do that assessment that I was talking about at the beginning so that I've got a heads up for what that's going to look like and how that might show up. Great question. Let's see. How, in what ways can dissociative patterns interfere with the therapeutic process? And how can we work together to address these disruptions effectively? So the best question that I can say is that dissociative patterns don't interfere. They are they're messages that your client is telling you about when things are too much. In EMDR, we talk about a window of tolerance, right? So if you think about from here to here is my window of tolerance. This is pain that I can tolerate. Anything above it, it's too much. I'm going into panic and I'm starting to freak out about what I'm experiencing. And anything below it is I'm dissociating. I'm out of my window of tolerance, right? So when somebody is dissociating, all that's telling you is that they are not in a place where they can go deep on a memory at that time. So if you've got a client that has a dissociative disorder and they are dissociating on a regular basis and they're not even aware of it, then we don't have any business getting into talking about their trauma at that time. What we have business in doing is helping them to learn more awareness about that dissociation, learning how to regulate their body and get more present, how to trust you in that process. And so the beginning part of therapy is all about that. It's building into the window of tolerance. And so I would not say that dissociative patterns interfere. They're the information that you need in order to get them into a safe place to do the hard work. So hopefully that's a great question, and hopefully that is helpful. I am not seeing another comment from Jay. But Jay, if you want to go ahead and email me that question, or you can DM me because I know we're Facebook friends, and then I can make sure that we get that question into the next Q&A and be able to share that information with everyone. So for everybody that came today and for everybody that watches the recording, I just want to thank you for patience as I'm working out the live pieces. I will definitely get better at those pieces. Thank you, Nia, for helping me out. For those of you that don't know, Nia Berry is our wonderful client care coordinator. We get so many clients that rave about Nia because she helps make them feel so safe when they're doing that brave first step of starting out for therapy. And so she's just an invaluable part of her for the journey, and invaluable today for our first dissociation Q&A hub. So thanks for everybody for being here. We're starting to wrap up. If you have any last minute questions, you can go ahead and put them into the as a comment, and I can now see them, which is great. And I guess I'll end on just kind of telling you a little bit about my hope for these Q and A's. I really want to make sure that we provide a place for therapists to just start to grow in confidence. So it needs to be a safe place. Really want to make sure that the people that come and are participating are warm and coming with open hearts and really respectful of each other, and make sure that we're respectful of our clients. So we are coming in here as therapists, but this is a live venue. As Nia is in here, she's not a therapist, she's our client care coordinator. These are live venues because I want to make sure it gets to as many people as possible. So if you have a question that involves a specific client, I just want to remind everybody to make sure that you change that information, that you take it into a place that is confidential. Maybe talk about clients in general instead of one particular client, so that we can make sure that we are respecting the privacy of our clients and keeping that safety, but also getting your questions answered. So thanks, Aruna, for being here. Thanks everybody else that popped in. I really appreciate it. And I look forward to, we'll be here next week on Wednesday, noon Central Time, 1 p.m. Eastern Time. And you can always email me at hello at hopeforthejourney.org, and get all of our questions in there ahead of time if you're not going to be able to make the live event. Thanks so much. Take care, everybody.